So, if I was to suddenly collapse right here on this stage, immediately many of you would call 911. 911, what's your emergency? And within a few minutes, the paramedics would be here attending to me. But if I collapsed on a similar stage in Nigeria, the most likely outcome would be confusion, chaos, and probably for me, death. Every single year, more than 6 million Africans die in different emergency situations, and that is 1.2 million preventable deaths in Nigeria. Most of the emergency services in Nigeria are privately owned. Frequently, they are not connected to any sort of central emergency dispatch. They are slow, and for the majority of people, there is simply no one to call. The global incident and emergency management market is estimated to reach $172 billion by 2026. In Africa, this will be driven by an increase in disasters and public health emergencies, a rise in demand for public safety systems and data, and a shortage of emergency service providers. This is why we decided to create Emergency Response Africa. My name is Folake Owodunni. I'm the co-founder and CEO of Emergency Response Africa. I have a background in public health and consulting, and I started this journey because I know what it's like to call 911 for my child. Together with our co-founder and CTO, Mame Poku, and a strong local team, we saw an opportunity to use technology to close Africa's emergency care gap. Emergency Response Africa is a service that connects anyone who is experiencing a medical emergency to help in minutes. We connect people to the largest network of first responders, emergency vehicles, and hospitals. Users can reach us on a toll-free line or a mobile app. Immediately, we dispatch a first responder to the scene. They can begin providing treatment after arriving on a motorcycle while an ambulance is still on the way. Now, if required, the patient can then be transported to the most appropriate hospital for further treatment. This system is powered by our powerful technology, which ensures smart dispatching, seamless communication, and data transfer from end to end, making sure that patients get the right help at the right time. We charge a fee for service, earning about 20% on each response completed. But we also work with corporate organizations and insurance companies, providing annual retainers to protect their staff and bundling our services into existing insurance products. Long term, we will support African governments to deliver emergency services to the public by offering them a turnkey platform to coordinate their emergency fleets. So since launching, we have addressed nearly 3,000 incidents in the country and onboarded almost 200 providers to our network in Lagos and 4 other cities. The best part is that we've seen a reduction in response times as much as 40 to 80%. We have been able to close partnerships with 8 corporate and insurance organizations and generated revenue over $10,000 monthly. Last year, we signed our first MOU with the state government to supply our technology to Ekiti State to coordinate their ambulance services. Over the next 18 months, our focus will be on expanding to more cities, adding 2 new emergency verticals, and driving more partnerships to achieve our revenue goals of $7 million by 2026. The MIT Sloan Africa INNOVATE Prize will enable us to add 3 new motorcycle medics to our network who, at scale, can actually deal with 6,000 cases on a yearly basis. We're also actively searching for partners and experts who can provide us with access to capital opportunities, but also expertise to improve our technology. We really appreciate this opportunity to stand before you here, and I'd love to say that emergency response in Africa is a significant untapped opportunity. I invite you to join us on this journey to transform this space. Thank you.
So we have like maybe time for one question.
The motorcycle medics, are they employees of yours?
Yes, at this stage they are, yes.
What's the future plan?
So the future plan is really what we're doing on the ambulance side. With the ambulances, we work with partners who have excess capacity. So they have a lot of ambulances that are sitting underutilized, and we use that excess capacity. In an ideal state, we should actually be reaching out to individuals in the community that are either medics or non-medics and actually training them to be able to provide that community-based first response. But I think that is more of a future state. For now, we do work with people who are on our staff for that particular portion.
Thank you. I could ask more, but I don't want to be the one that.
All right, thank you for watching.